Our next speaker today is Marijo Ratcliffe. She completed her undergraduate degree at St. Louis University, her master's and pediatric nurse practitioner at the University of Washington, and her doctor of nursing practice at Duke University. She is currently a pediatric nurse practitioner in the pulmonary department and practicing in the chest clinic at Seattle Children's Hospital, and clinical assistant professor and nursing faculty on the Interdisciplinary Education Pediatric Pulmonary Center training grant at the University of Washington. She is also teaching pediatric pulmonary classes at the University of Washington School of Nursing. She previously worked in inpatient critical care at Seattle Children's Hospital and Harborview Medical Center and was a discharge coordinator at Seattle Children's Hospital for high-tech dependent infants and children with pulmonary disease. She has participated in asthma research and numerous asthma programs in both the community setting and hospital setting, and is currently working with neighbor care health school-based clinics in developing an asthma program. Recently, she completed a quality improvement project in children with moderate to severe asthma during the previous viral season. Welcome, Marijo.
So just so I know who I'm talking to, who am I? Where is everybody? Who are the people I'm seeing?
The people you're seeing are from all over the state.
Oh, okay,
So,
great.
Plus here.
Plus here,
So,
great. Well,
yes,
welcome
we have 12
everybody.
sites.
12, great, okay. Well, thank you very much for inviting me. I'm happy to be here. I have to tell everybody whenever I start talking to school nurses that one of the reasons I care so much about it is because my sister is a school nurse. She's a school nurse in the Chicago area where we all grew up, and I probably talk to her at least once a week about problems that she has. I'm just blown away at what school nurses do have to do. And I think her biggest problems that I hear about anyway, are asthma and diabetes. I don't know if that agrees with all of you, but that seems to be the two conditions that really keep her very busy. And she's in a school-based clinic. She's in a clinic with children with special health care needs, an elementary age group. So she's pretty darn busy. So I, of course, talked to her before I even talked about doing this, asked her some of her issues as well, and was really happy to get some of the issues that I heard about that were sent in through Lynn and Hannah to address today. So I'm going to kind of talk about some of the dilemmas I think that you come across when you have a child with asthma in a school setting. And I think the one thing that probably my sister has really emphasized on me is that many times you are the only person in the building with the healthcare background, and you are the only person with the clinical judgment. And so you really feel the responsibility of this very heavily, which I understand completely. No disclosures. So we're going to talk a little bit about children that have problems in the school, and I'm going to try to do it really through a perspective of a case, a couple of kids that have case history or a case example of a child with asthma. So I want to talk about asthma management based on that child's symptoms that's presenting and their severity, review the information required to how you make a decision at the time with the kind of information that you have available and the kind of technology you have available, and then summarize the impact of intensive asthma management on school attendance. So I did a program that was very interesting, and one of the things we found out in our QI project was that we actually could keep kids in school if we did something. So we learned a lot by doing that. It was very interesting. So this particular child is real, okay? 7-year-old Kylie is a second grader. She's overweight. She has a history of asthma since about 2 or 3 years of age. Her mom has informed the school nurse of Kylie's asthma, quote, just baby asthma really, and has not seen her primary care provider since last asthma attack, and she thinks it may have been last fall or last winter. Not sure how long it's been since she used her inhaler. Yes, I think it's called albuterol. Yes, I think it's kind of red. And I think it might be at her dad's house now, but we'll get another one for school and we'll find the space or two. Common problem. Is that correct? Does this ring a bell to you guys too? Good, okay. Mom had to cancel the last primary care provider appointment when Kylie was sick, but has another appointment in 2 weeks, and we'll get the asthma management plan then, and we'll fill out the school forms for Kylie to have albuterol at school, and promises to bring the asthma management plan after seeing the primary care provider, and bring the albuterol inhaler tomorrow, and the spacer too. So, promises. The trouble is, Kylie's coughing in class all the time, and her teacher is frowning quite a bit. She's supposed to go to PE now and then lunch with recess after lunch, but is coughing so much that the teacher sent her to the nurse's office. Kylie hates PE anyway, so she's happy to go to the nurse's office until lunch. That's fine with her. And she told her teacher she was coughing and threw up last night. She's really tired today. Her chest and her stomach hurt. And this seems to occur quite frequently because the school nurse knows these children very well. And she certainly seems happy in the office. So, what are you supposed to do, right? There's a lot of stuff going on here. What's really interesting, let's back up just a little bit. This slide depicts how hospitalizations will peak for kids with asthma every September, which is not a shock to any of you, I know. Not a shock to me either, because I'm in chest clinic and unbelievable amounts. School starts 2 to 3 weeks later, I start getting lots of phone calls and seeing lots of kids trying to squeeze in. So therapy really should be at its best level by mid-September. Its peak level by mid-September, which means you have to start in mid-August, really, with controllers. So some kids that are coming off their controller medications in the summertime, or parents will take them off their medications in the summertime, really need to start them back up again by mid-August, because then you're really getting the effect by the time you're hitting school and you're getting all the viral insults. So this slide is showing a cyclical pattern of asthma hospitalizations in children, and this was from a study from 2 to 15 years of age, over 15 years, with yearly peak occurring in September. So every peak you see there is a September peak. It's unbelievable. It happens all the time. We all know it ahead of time. It's just hard to deal with. So the asthma hospitalization rates are depicted as multiples of weekly mean hospitalization. So that's the y-axis. The x-axis is the years. Very interesting. And what's also interesting is children with allergies and atopy or eczema allergies, when contracting a virus, will have more significant asthma exacerbations. So what this slide is showing is the percentage of viral infections determined to be asymptomatic, mild or moderate or severe, depends on allergic sensitization. So on the, on the right, on your left, is non-sensitized children, or children that don't have as many allergies. So, but the ones on the sensitized, on the right, have certainly more exacerbations. They have more intense exacerbations, and they have more severity. So if you have a child with just straightforward asthma, it's an IgE-mediated disease. So we know that you can have allergies, you can have eczema, and you can have asthma. They're all IgE-mediated. Some kids are lucky and get the full meal deal. Some kids only get 1. Some have 2 out of 3. It's really variable. But the kids that have allergies and asthma and eczema, that kind of history, are the kids that when they get a viral illness, they have much more severity involved many times. So obviously the underlying problem is to control the allergies and the asthma. And that includes allergic rhinitis. A lot of kids have allergic rhinitis and don't really deal with it. They don't really get diagnosed. They don't really talk about it. And that really complicates their asthma as well as their exacerbations. So there's a lot of comorbidities that will also involve greater exacerbations with your asthma too. So if you have gastroesophageal reflux disease, and 30 to 40% of kids with significant asthma have gastroesophageal reflux disease, so severe, moderate to severe asthma. So that's something to ask about. We do know if a child doesn't have any symptoms of GERD, there's no point in treating them, even if they have asthma. That research has shown us it's really not effective. But if they have symptoms and they have moderate to severe asthma, they should get treated for their GERD as well. If they have allergies, that's another comorbidity, as I mentioned, food as well as environmental. Allergic rhinitis, I said some research has said up to 80% of the kids with moderate to severe persistent asthma have allergic rhinitis, probably reflecting their allergies as well. Obstructive sleep apnea will make asthma worse as well. Whether it's a chicken or the egg, it's really hard to say. Obesity has a big impact, and it's a very different ballgame when you're treating an obese child that also has asthma. Dysphagia, or kids that have trouble swallowing. Any child that is hypotonic, any child that is globally developmentally delayed or developmentally delayed and has any hypotonia and they have asthma, many times they are aspirating as well. Those children really have more problems too, and they need to have treatment for their dysphagia as well. Vocal cord dysfunction is now called paradoxical vocal fold malformation. So PVFM is really the word for it now, or the icon for it now. And that really needs to be evaluated as well. And a lot of children that Robin was even referring to that probably has anxiety attacks may have some paradoxical vocal fold motion as well and needs to be evaluated for that. So if you really have normal lungs, but you're having what appears to be a severe asthma attack, it can really be upper airway and not lower airway and probably should be evaluated. That's a comorbidity that's not uncommon. And obviously depression and anxiety, as Robin mentioned as well. So the other triggers that complicate it, you don't have to be allergic to something to have a trigger be an irritant. So smoking, a lot of people will say they're allergic to smoke. It's not that they're allergic, it's just that smoke is irritant. I agree completely with Robin's point of view. Let's have an odor neutral world. Even though we all like nice smells, but oh my goodness, odor neutral home and an odor neutral school would really go a long way. And it's not as if that's going to trigger a child to have an exacerbation, but if there's 2 or 3 things going on, like the child has a cold, they were at grandma's house last week and they had a cat, and now they're at school and they're smelling this whatever, 3 things, boom, you know, that can just put them over the edge. So these are other triggers that can certainly lead to problems as well. And I think we see a lot of kids from Eastern Washington too. And so I don't know if we have Eastern Washington people online, we probably do. But boy, I sure see a lot of people when it gets windy. I see a lot of people during harvest season. I see a lot of kids when it gets windy. So obviously, the air quality makes a huge difference. And it doesn't look like bad air quality necessarily, but it is for children with asthma. And then once again, a lot of people think because exercise is a trigger that they need to limit the child's exercise. And that's actually the opposite of what we're all trying to do. We're trying to treat them enough so that they can be a normal kid and run out and play. So it's good to know what the early warning signs are, and this is something I think that school nurses probably get pretty good at, especially with individual children, because every child will have their own way of kind of expressing some of those early warning signs, and you don't want them waiting until the late warning signs show up. So this is something, just early warning signs: coughing at night, sighing. A lot of kids will start with, they're probably getting some swollen airways, and they're starting to sigh a bit. A lot of kids will start throat clearing. Exercise intolerance will start showing up. They start to engage their abdominal muscles on exhalation, but by the time that's occurring, you can imagine that their airways are starting to get swollen. That's not really a very early sign. Cold symptoms are part of that. And audible wheezing comes much, 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 much later. It is not an early sign. By the time you're hearing wheezing, obviously the child's airways are all involved. So what you kind of have to figure out is how you're going to treat this. If you decide the child is in an exacerbation, how you're going to deal with it, especially in school when you don't have everything around you. So hopefully you start albuterol the first sign of a cold, or the family does. We use 4 puffs, especially if a child has had a history of ER visits, hospitalizations, urgent care visits, oral steroids. A lot of people, I can't remember, I can't even tell you how many kids I've seen lately in chest clinic who are coming in and are being told to take 1 puff every 4 hours if needed. And it's just not cutting it. 1 puff doesn't cut it. And you know, if you go to the ER, you're going to get 8 puffs right off the bat. So explaining to people that, you know, 4 puffs is actually a normal dose. A lot of people can start at 2 and do just fine, but 4 puffs is a normal dose. And if you're having trouble and you're sick, you don't want to be holding back and waiting to see what's happening. If the albuterol isn't working for up to 4 hours, and it does start working within 5 to 10 minutes, it's pretty quick. If you use a spacer and the appropriate technique, it'll work pretty quickly. And if it's not holding a child for 4 hours, then the family needs to know, I'm sure. If there's increased work of breathing, coughing, wheezing, or getting worse despite the albuterol, then obviously the family and the primary care provider probably need to know. And then I'm sure what you would try to do is have a good system in place already, that the parents have filled out their asthma management form, or they filled out whatever forms they need to, so that you know you can call 911 if you need to. But I know that that's different with different school districts. After 24 or 48 hours of albuterol, if a child has been on that for a couple of days at home and hasn't been getting better, or is getting worse even despite that, having more trouble sleeping, having coughing even despite that, then more often than not, that means, albuterol, all it does is relax the muscles around the breathing tube. So if they're still getting worse despite the albuterol, then they've got a lot of inflammation building up and they need the inflammatory treatment. So you can give albuterol till the cows come home after a while, and that's why I think a lot of parents will say it just doesn't work, because you get to the point where you got to treat the inflammation, or even more so, the receptors in the airways themselves. If you're using albuterol all the time, frequently, and we don't even know what all the time is, but daily for a long period of time, then those receptors become less responsive, and over time, there's probably some kids that then don't respond to albuterol, and the parents are right, it's not working. And rarely, I think the main thing to remember is rarely do you have a sudden onset of asthma in the school, on the playground, or somewhere that's really going to cause that child to just collapse. It's rarely a sudden onset. It's usually 2 or 3 different things that have been percolating for a while. They haven't been treating very carefully. They haven't been taking controller meds or haven't been using albuterol, and then all of a sudden, bam, that child gets really sick. I think that's reassuring for most families, but it's not reassuring if they tend to ignore symptoms, which a lot of people do. So you want to really, if you are trying to figure out, is this a really severe exacerbation, some of the things you can do that Robin was also talking about, but also to find out when did those symptoms, exacerbation isn't a word I would use, but when did those symptoms start and what triggered it? What meds are usually taken, how often, and are they effective? So if that child is supposed to be on controller medications, and they started it when the cold started, but last winter they were in the ER twice and they had steroids twice, then that child's already primed. They're going to have more problems. So you want to know if they're on Advair, if they're on Dulera, if they're on Symbicort at home or something like that, which are the combination drugs. If that child needs those drugs, then you know their exacerbation is probably going to be worse than somebody who uses albuterol only with a cold. So it's good to know how often and what kind of drugs they're taking. Have they ever been in the ICU? Have they ever been intubated? Have they been hospitalized? Have they been in the emergency room? And what is their frequency of oral steroid use? So all those things are things like Robin was talking about that actually heighten your, puts your antenna up like, okay, this kid might have a lot more problems than a child that just uses PRN albuterol. And if you're in any school systems and special schools that have a lot of children with special health care needs, then looking at their history and their comorbidities that may be involved really makes a difference. Like, were they born early? BPD being bronchopulmonary dysplasia. Were they preemies dysphagia? Are they having aspiration problems? Have they had a history of pneumonias? Because recurrent pneumonia many times presents as untreated asthma. So it's really common that we see kids with history of pneumonia, but what they really have is asthma that's never been treated. Reflux, do they have a lot of gastroesophageal reflux? Do they have allergies? Do they have chronic infections like sinusitis and otitis? Because there's a lot of other problems that can go along with that. So that kind of gives you an idea. If this child has this kind of history, then that exacerbation might be more severe than somebody else. So when do you worry? Well, Robin talked about this too, but the biggest worry is that they're unable to say more than a few words without stopping and breathing. They can't walk and talk. That's just way too much trouble. It's really hard for them to breathe. They have to sit up in order to feel like they can breathe. A lot of them will sit up like this with their shoulders hunched too, because that gives them more lung volume. If they're head bobbing, whoa, that's pretty severe. You see head bobbing in babies, but not in older kids. But if they're head bobbing, that's a very severe exacerbation. If they're confused or less responsive, or even worse, don't care what's happening around them because all they care about is breathing. Obviously, those are severe warning signs. That's 911 or more. So what's interesting is I also put a slide in here that you can lose control of your asthma and get an exacerbation, but it doesn't, as I mentioned, happen suddenly. It usually develops over 5 to 7 days. And this was actually a study where they looked at severe exacerbations, and this particular red dotted line in the middle is when the exacerbation became very effective. And on either side of that is the buildup. So the left side of that is the buildup. The symptoms started, and they were looking at 2 different drugs here, which really don't matter. It's the blue and the green drug here. They're combination drugs, and it really doesn't matter what drugs they were taking. But the point is that most kids will start having symptoms for 5 to 7 days before they actually have an exacerbation that everybody is jumping up and down about. And if they started treating it early enough, and if everybody knew the early warning signs, then actually it makes a huge difference in preventing that exacerbation. However, if they don't, then usually the exacerbation gets to the point where they have to treat it very vigorously, And then resolution takes even longer. So if you build up over time and you haven't been treating it and you haven't been taking your control meds, or you have maybe eczema, plus you have some allergies and you have some asthma, then your exacerbation is going to be a lot worse. So it's very interesting that we can prevent a lot of exacerbations if everybody is on the same page with regard to monitoring early. And this is very interesting too. How long does it take to get over the last cold-triggered exacerbation? So we all think when the symptoms are gone, then the child is better. But this was very interesting. It's looking at the rate of recovery from acute asthma, and the very top flag, green flag there, is peak expiratory flow rate, and that the x-axis is hours, days, weeks, and months. So if you look at peak expiratory flow rate, their peak flow is going to improve within days when they're getting over an exacerbation. The middle one is FEV1, or how much air on spirometry they're blowing out of their large airways. Now, FEV1 and peak flow are roughly equivalent, but not really. But that's the best. I mean, if that's, you've only got a peak flow, you've only got a peak flow. But when you compare peak flow and spirometry, is FEV1 is a lot more accurate. And you can see that one is going to take almost weeks to get better, despite the fact the symptoms are gone. But the small airways, which is the lowest one there, will take weeks to months sometimes. So a kid can look fine, and the parents can say, no, he had a cold last week and he's just fine. But if he gets hit with something else next week, or he was at grandma's over the weekend, or they went camping where they had a fire, or things like that, that child's airways are already primed, and sometimes it'll take weeks for those airways to go back to normal, especially if the child has more persistent asthma. And I think the easiest way to evaluate if a child has persistent asthma, and I didn't hear the beginning of Robin, so I'm not entirely sure if he talked about it, but did he talk about the Baylor 2 rule? It's easy to remember. A little bit. So if you have asthma symptoms more than a couple of times a week outside of exercise, let's say, if you're waking up or having asthma symptoms more than a couple times a month at night, if you're using more, they say more than 2 inhalers a year, and they had one other one, I think steroid bursts, 2 per year, then you're in the persistent category. So the easiest way that I go through it with parents is to say, how many times a month do you hear symptoms at night? And I never ask, do they wake up? Because if they don't wake up, then the parents say no. I don't care if they're waking up or not. I want to know if they're coughing at night, and are the parents close enough to hear that? Because if they're upstairs, or if they're in a bedroom 3 bedrooms away, they don't hear it. So you want to know if they're having symptoms at least twice a month at night. And during the week, are they having asthma symptoms where, doesn't mean they use their albuterol, because a lot of kids will try to not to use it. They don't want to go deal with it. They tough it out, especially teenagers, for sure. They don't want to use it. So I don't ask, how many times do you use your albuterol every week? I just ask, what are your asthma symptoms like every week? And if you hit that too, then you have enough inflammation in your airways to give you symptoms. You need to be on a persistent, you are persistent, you need to be on a controller medication. So if you should be on a controller medication and you get one cold after another, your small airways are going to take a long time to get better, and you're going to be sicker faster. And that's why I think some people say, my God, he seems fine, and then all of a sudden he's sick and I have to go to the ER. Asthma severity levels, as I mentioned, are intermittent, where they only need medications with colds or activity, and then persistent, as I talked about. Once you reach that level, I use the Baylor method of 2. I like that one. And there's treatment levels, steps 1 through 6, where you start out with just albuterol and you go all the way up to a combination drug of an inhaled steroid with a long-acting beta agonist, and oral corticosteroids many times are needed as well. So there's my Baylor. I forgot. There it is. So that's their actual rules. So 2 doses of beta agonists a week. But once again, a lot of kids don't use that. So I don't necessarily say, do you use your albuterol? 2 nocturnal awakenings per month. I don't really care if they wake up, as I mentioned, just if they're having symptoms. 2 beta agonist canisters a year, 2 unscheduled visits per year, which is another good one, and 2 prednisone bursts per year. So once you hit that, then you're in persistent category. So when asthma is controlled, life is a lot better for everybody. Good control means more sleep for everyone, less school absence, less parent missed work, better quality of life, reduced exacerbations, reduced healthcare costs, but it often means more medications, and a lot of people don't want to do that. Poor control is associated research-based. Less physical activity and fitness, increased obesity, deleterious impact on cognitive functioning, and they're getting that more and more in adults now, so eventually we'll have the research that shows it actually happens with kids as well. Poor growth and delayed puberty, and in adults, some of the psychomotor tests have revealed less attention, less focus, and mental flexibility as well. So it's and sometimes that's what is actually helpful to portray to parents as well, is if they understand that there's probably some cognitive impact over time without managing this child's asthma. And no asthma symptoms doesn't mean no asthma. A lot of people think that once they get under control too. So this is just a stepwise approach that comes from the guidelines. Unfortunately, our guidelines came out in 2007. So, God, 10 years. We keep saying we're going to get more. Every year, Europe puts out new guidelines. They have adjusted. They're called GINA, G-I-N-A. They put them out every year. So there's always more information and more research that we can refer to as well. But this is just from the 5 to 11. So, they go from 0 to 4, 5 to 11, and greater than 12. This is looking at severity of intermittent, and then mild, moderate, and severe, and the stepwise approach for treatment. And this is the one for kids greater than 12. They're very similar. And 0 to 4 is quite different. This is the increasing medication use that starts out with just PRN albuterol and ends up on the drugs that I was just talking about. And then finally, there are more and more, there's going to be more kids on biologics. They're called biologics, like Xolair, which is an anti-IgE medication. It's an injection you have to get usually twice a month. It's for the kids that have bad asthma and really bad allergies as well. They have to have a certain level of IgE level in order to qualify. It's an extremely expensive drug. It hurts a lot when you get the shots. You have to go in twice a month and get them. But it's getting to be more and more, less and less uncommon, I should say, and there's about 2 or 3 others that are coming out. And this is kind of moving towards personalized medicine. It's actually figuring out exactly what kind of genes or DNA that child has and what kind of medications will actually affect it. So we're going to see more and more of that. Any child who's on Xolair, though, is significantly impacted by their asthma and their allergies. And Lynn, remind me again, how long am I going, or Hannah? Just keep yakking? Okay. Yeah. I won't do that to you. But tell me, give me a guideline. What are we?
Can you put the microphone a little closer?
Oh, I'm sorry. Okay. So,
Well, we had you going until about 3:15, but
okay.
about 3:05 for questions.
Okay.
Yeah.
Okay. That sounds good. Great. So when you have children that aren't in good control, what are some of the common reasons? This is looking at, number 1, poor inhaler technique. Ooh, my slide didn't show up very well there, did it? I do know how to spell technique, I promise. Oh, none of it looks good. Poor adherence to therapy and misdiagnosis. This is terrible. Oh, well, sorry about that. So there's an awful lot of children. So if you look at this slide, obviously the cat is just kind of making fun. The little boy that's there is a toddler. He's still in diapers. He's very well. He's trying to use his inhaler and his space mask and his spacer, but that child is nowhere near strong enough to pump that thing. And nor does he have it, his nose is over here. So the point being that there's an awful lot of children that don't, unless you actually watch them use their medications and correct them when they do it wrong, they're not getting the drug in. The little girl in the lower right-hand side is not using a spacer, which is a no-no for all of us, even adults. We say, and we have all kinds of evidence that it makes a huge difference. And then the child, the little boy on the left, or I guess it's on your right, on the lower right, is using a dry powder inhaler, and he does not have the inspiratory effort to do that at that age. So that's inappropriate too. So he's probably not getting the drug. None of these children are getting the drug. And many times the parents will say, we give it all the time. But if you don't look at their technique or really figure out, are they using it properly, doesn't matter if they're using it, it's not going in the right place. What's interesting though, is even if you have great technique, you don't get a lot of drug in. So you really have to have perfect technique in order to get enough drug to make a difference. So using a spacer, you can get anywhere from 30 to 60% when you use it appropriately. So 60% is great, When you're using a dry powder inhaler, the one in the middle, like Advair, you get about 15 to 30% of the drug in. This is all documented too. And if you're using a nebulizer, sometimes you're only getting up to 10%. And if you're not using it with a mask, you're obviously getting less. And some of the a pharmacist once told me, if you're giving that nebulizer and holding it in front of their face, you might as well take the drug and pour it down the sink because it's not going to give them enough drug. Most of it's going out into the air. So technique really does make a difference, and you can tell if a child has had it because they start getting, when they're getting a beta agonist, because they start getting some side effects. They should be able to feel something. They should have a little tachycardia. They should have a little bit of a tremor. I had to take these drugs for a while. It was very interesting how I felt, and I know what people talk about now and why they don't like them. I don't know if anybody in here has asthma and uses albuterol, but it's uncomfortable. And you can see why people don't want to do it, but it does make a big difference. As the size of the particle and the flow increase, more particles tend to become trapped in more central regions of the airway due to impaction, and that's why you want to use a spacer. So if the patient takes a deep breath and holds it in, the quantity of the medication retained in the lungs can increase up to 17%. So that's one of the reasons why, even if you don't, you might get on the low end of like 15 to 30% if you don't hold your breath well. So most of the time, once you hold your breath, it actually, because diffusion occurs in your lower airways, it makes a huge difference. The longer you hold your breath to get those tiny little particles out into the small airways that are already tight and swollen anyway. So if you can do that and hold your breath and last longer than 10 seconds, like I tell kids, if you can do 20, that's even better because you're going to get more drug in. And then the next time you take in a big breath, if you held your breath a long time the first time, the second one might get in a little bit deeper. So it's really helpful to disperse the drugs by holding your breath as long as possible as well. So what's interesting is, spacers, if you go to the pharmacy and buy them, they are really expensive. But you can go online to this place, and this is a Monahan spacer that is $10. So my sister told me about this. So she's telling families about this because a lot of people don't use spacers because of the cost. And they want to have them at grandma's house, and they want to have them at daycare, and they want to have them at school, and all this. So if you can find them for much cheaper, that's a lot better. These are Monahan spacers. I was very surprised. So worth it. And this is obviously instructions. I think, front loading, meaning taking the time to go through watching the child use the drug and use it correctly makes a huge difference in the long run. So actually going through all the steps is very helpful. And some of the things that I mentioned this to my sister as well, but I was thinking about it when Robin was talking. This is called the asthma control test, and I don't know if you're familiar with this. It's a very easy test to take. So on your left is the asthma control test for teens or 12 years and older, and on your right is the one for younger children because it's just bases. And they ask questions, specific questions like, how much trouble is your asthma? Could you sleep last night? How often are you using albuterol? Things like that. And you get a score for all this, for each particular category. If you have a score of 19 or less, then theoretically your asthma is not in control. If you have a score 20 or greater, then theoretically your asthma is in control. And I can tell you, this is a validated tool, and it's online. It's very useful, I think, in the setting where you can't do something like spirometry. You don't have the equipment to really see what's going on in the child's airways. It is all subjective, though. It is not objective. And when we do both of these in clinic many times, and I will have kids who score very well on the asthma control test, but when I do their spirometry, they are not okay. But they feel fine because they are used to this. They are used to the dyspnea. They're used to that shortness of breath. It doesn't bother them anymore. But it's very helpful at least to get a general idea. Just really quick questions. Is this child's asthma in control or not? It's just kind of a quick and dirty way to do it. And then I think what I've also found, and I'm sure you do this all the time, is nobody knows what drugs are on. Nobody knows the name of their medications. And so I constantly use pictures now too. So they can at least point. The problem is ProAir is red and Flovent is kind of orangey red. And so a lot of people get them mixed up, or they just say, I'm on the red one. The other thing I think is very helpful is if you constantly don't let them just use the word inhaler. When did you use your inhaler? Well, there's a whole bunch of inhalers. So you want to know, do they want to just talk about albuterol? Then you say the word albuterol. If they're on Flovent or they're on Qvar, that's an inhaler too. It's really helpful to say, do you mean Qvar? Do you mean Flovent? What do you mean? So that they learn the names of their drugs as well. So pictures really help. At least they can point, and then you can say what the word is. Same with, there's pictures like this in the asthma book here at Children's, and I think they're also online too. You can find a lot of these now, and they're very helpful. So that at least the child can say, yeah, I take that one. And also visual resources are very helpful. So National Jewish has some great asthma programs, and that is something that you can even refer parents to as well. And Children's also has some great asthma programs going on. So these are websites that you can use for them. And then I wanted to talk a little bit about the QI project that I did last year. We developed an asthma clinic in the height of virus season with the worst of the worst kids. We were trying to see if we could actually control children with bad asthma during viral season when they usually had the most problems. And these were kids that were being referred in because their asthma was out of control. So we tried to reduce their asthma morbidity. We also tried to only deal with kids with persistent asthma. They were between 5 and 18 years of age. We started out with 26, we ended up with 15 kids because it was during the school day and there were transportation problems. I mean, on and on and on and on. There's a lot of reasons why people dropped out, but we ended up with 15. They were very diverse, predominantly covered through Medicaid, and because we live in the state of Washington, we actually can cover most kids. Hopefully that stays that way, but we didn't have any kids without coverage, which was really nice. So we could get medications for everybody, which makes a huge difference. At baseline, the majority experienced poorly controlled or not well-controlled asthma, and you know that's specifically in the guidelines, so we followed the guidelines exactly. In the setting of moderate to severe persistent disease, and we managed them intensively for 4 months. So we saw them every month for 4 months, and after every visit that we saw them, we called them 2 weeks later, and we asked them if they were having any problems, if they had gotten their medications, if they had been sick. We asked them all kinds of things, trying to more or less really give them access to, because there were a lot of questions that would come up. Well, I think you might have a cold. And we'd say, well, have you started your albuterol? Well, it might just be a cold. We'd say, you know, it was really hard to say. No. First of all, colds trigger asthma. So it doesn't matter. You want to treat that cold like asthma, because asthma equals cold when you have asthma. You don't want to wait 2 or 3 days to see if it's really asthma. And a lot of people still do that. Even though we talk about that, we found that we needed to reinforce that over and over and over. It doesn't matter if it's a cold or asthma. You need to treat it if you have asthma. So calling them 2 weeks later was helpful, other than we found, and I think this is probably true in many situations, there were at least 40% of the people who did not speak English. So even though we would call with an interpreter, they didn't answer the phone because they don't want to answer the phone because they're not sure who's going to be on the other end. And so it was a little bit difficult sometimes, but it was really worthwhile, the people that were having trouble, to talk to them even 2 weeks later and find out what they were thinking, despite what we had taught, what we thought we had taught. Made a huge difference. So participation itself, though, was associated with significantly reduced school absence. We kept those kids in school if we were managing them intensively, and these were the worst of the worst. They'd all been in the emergency room, in the hospital, on steroids, so they were pretty significant asthma. We kept them out of the emergency room. We improved their pulmonary function because we were checking their spirometry as well as we were doing the asthma control test, as I mentioned. We improved control for most of them. So I think when we started out, we had 6% of the kids that were in control, 6%. When we finished, let me see, we had 6% in control. We had, the rest of them were not well controlled. They were really poorly controlled. By the time we finished, we had 45% in control, and we had 6% not in control. So even though we were doing a lot every 4 months, we were seeing them frequently, it takes more than 4 months many times to get asthma under control when you've been out of control for a long time. But at least during the height of viral season, we found that we could get kids significantly back in school and keep them in school and out of the ER and out of the hospital. So that made a huge difference. And this was some of the results that we had. So this is looking at asthma control. Visit 1 is on your far left. Visit 2 is next. Visit 3 and then visit 4, and it's looking at control. So by the time we hit visit 4, you can see poorly controlled is the very top. That's kind of that murky green color. So we really did improve a lot, but we didn't get everybody under control. It takes longer. And we looked at ED visits. By that 4th visit, you can see everybody stayed out of the ER. And the month before we started, we had, almost 60% of the kids had been in the ER. So a lot. And we started this in October. So we started it, when they'd all gotten sick in September, like they do. School absences, you can see we improved it significantly, but we didn't keep everybody in school. By 4th visit, which is, did they have a school absence? The red part is yes. They significantly improved. You can see 80% had missed school the month before when we had started, because September is such a mess. But by the time we finished in early 2016, actually, we were at least keeping most of them in school. So if we go back to Kylie anyway, with a typical scenario that we talked about, how significant is her asthma? Well, she has chest pain from asthma. She was throwing up last night and has stomach pains due to post-tussive coughing and not a GI problem. And her mom's perception is this was a GI problem because her stomach was hurting and she was throwing up. But she had post-tussive vomiting. She was coughing, she was so tight, and she was coughing to the point where she was vomiting. So it's not a GI problem, it was a lung problem, it was an asthma problem. Her asthma is clearly out of control. She has a night and a daytime cough. She had increased frequency of symptoms, and she had difficulty with activity. She was complicated by her weight. She was not on any controller medications, which is clearly indicated in this child. There was a lot of family chaos. There were 2 homes. It was hard to keep meds in both homes, and the child was going back and forth. And they had very infrequent primary care provider follow-up. And this is not atypical. I know you know all this, but this is not atypical. We hear this all the time, too. She has minimally moderate persistent asthma based on her symptoms and level of severity, and she's poorly controlled. So once you kind of categorize that, you can say, okay, this child should be on these medications. She's not on these medications. This exacerbation may be quite significant, actually. And cough is a huge symptom of asthma, and wheezing comes much later after most of the lower airways are inflamed. So we really are constantly trying to also educate families. Don't wait for or look for a wheeze before you initiate treatment. And a lot of people will wait for that wheeze to start. Or they wait to make sure it's not a cold, as I mentioned. So you're the only person in the school with a health background. So you want to obtain as much objective information as you can. So can she walk and talk? Can she lie down without distress? Is she tachypnic? Is she engaging abdominal muscles on exhalation? Is she hunching her shoulders and sitting up? Is there any nasal flaring, which is pretty uncommon in an older child, but certainly can happen? And no, Kylie was quite okay in the office, but said she had a runny nose all the time. So maybe she has some allergic rhinitis on top of it, hard to say. Lift her up. It's always, if you can, and it's not totally, you have to get them in a place where it's private. You really want to see that chest wall and see if they're working to breathe. I mean, a lot of times I snake my stethoscope up underneath their shirt if I'm trying not to embarrass them, but I always look. At some point, I have to take a peek and see what their chest wall is doing, because if they're working hard to breathe, you're going to see that. So you want to listen to her breath sounds, and you want to compare right and left from the shoulders to the diaphragm, back and forth. And Kylie had scattered wheezes on expiration with big breaths. So sometimes if you don't take a big breath, you're not going to hear that, but you will hear it if you can get the child to take a big breath. No inspiratory wheeze, which is good. She had a really junky sounding cough during the exam. So initially, your airways start to get swollen. You can get your air in just fine, but when you're starting to breathe out, you're just starting to push. And so you can see their abdominal muscles just starting to push a little air out. And if you make them take a big breath and then blow out hard, that's when you might hear some scattered wheezes in the very beginning as well. So if there's peak flow available, it may help if she does it correctly and it's available. And she was able to do a big blow correctly without coughing, which is a big deal. Because if you're really tight, you're going to cough when you take a really big breath. And she was within the normal range for her height. Even though you don't know her best, that theoretically with peak flows you have to know the best. But you can at least have a chart saying what their best should be based on her height. And that's available online as well. And her saturations were 97%. I know not all schools have SAT monitors, but if you do, that's really helpful as well. And as I mentioned, you could do a quick and dirty asthma control test just to see if she has any symptoms that indicate her asthma really isn't in very good control. The asthma control test just asks questions over the last 4 weeks, but a 7-year-old, 8-year-old, 9-year-old could at least answer those questions. So what do you want to do? Do you want to treat this child, or do you want to call out for help? So who do you call for help? It's a good idea to line up your safety nets, whatever they are, because as I mentioned, I know it's really uncomfortable to be the only person with the medical background and the medical clinical judgment in the whole building, or even worse, on the phone. So Kylie's not going to do well outside in the cold air. She's having a mild exacerbation. She needs a bronchodilator, so it's not a great idea for her to go outside in the cold air to have PE or recess, unfortunately, even though she would rather stay in as well. The family does need to see the primary care provider. Kylie does need a controller med. You need an asthma management plan for both households, so hopefully the primary care provider could do that. The meds should be brought to school. The school form should be updated. The parents need to meet with you. And I don't know how often you get all that, but that is the ideal situation, obviously. When asthma's under control, unless she's getting over a cold or in the middle of a cold, she can do normal activities with PE. She can pre-treat, she can do normal activities. So unless she's in a cold or she's just getting over a cold, Kylie can participate. And a lot of people think their kids, and I get asked to write these letters a lot, keep them out of PE. They don't have to go outside. And I never do that. I really ask a lot of questions before I do that because we want these kids to be active and running around, and we can pre-treat. So if she was in real distress, obviously 911 and the parent gets called, family needs information. The fact that this is something that you probably mention all the time too, and I know I do, is that asthma is not gone if the symptoms are gone. It doesn't mean the asthma's gone. Providers can help decrease medication systematically with plans to increase or decrease if the symptoms change. So a lot of people are really afraid. I hear this from people too. They're afraid if their child gets put on these inhaled steroids, which the word steroid always is a big red flag, that they are going to be left on these drugs, and it's not, and I keep telling people, it's not like adults. We don't put kids on drugs and just leave them. If we evaluate them, and what we found in our lit research as well as in our QI program, if you see somebody with moderate to severe persistent asthma at least every 3 months, they don't lose control. If you see them more than 3 months, if they're 3, 4, 5, 6, 7, 8 months without being seen, they tend to lose control. So we can absolutely manage their meds better and decrease them when appropriately or increase them when appropriately if they're seen about every 3 months. So that's something that's really helpful for parents to know as well. But it's been documented. Those kids lose control if they're going 4, 5, 6 months without seeing anybody. Parents need to meet with you, obviously, and Kylie still needs a primary care provider. She needs a controller med. She needs an asthma management plan. She needs her meds brought to school. She needs a spacer at school, but you can get a cheap one now, and updated school forms. So when asthma's under control, unless she's getting over a cold, then she can do activities, as I mentioned. Good news is asthma can be controlled. You'll have help in controlling asthma with your provider. You can learn to control your own asthma, especially kids that are older. With good asthma control, you can probably do whatever you like. Well, not whatever you like, but you can do most activities when you're not sick. And I always talk about this with kids too. There's a lot of Olympic athletes that have asthma, and they have learned how to manage their asthma so that they can actively participate in activities well beyond what we normally do. So it is possible to have asthma and be an active child. Asthma, the bad news is though, asthma is not curable. It's not preventable yet. Asthma is a chronic, lifelong disease most of the time. I can tell you out of all the children who get asthma from the time they're very young until older, 2/3 of those kids are going to lose their symptoms. 1/3 are going to keep their symptoms. So 1/3 are going to track and have asthma. If they're severe when they're young, they're going to be more severe when they're older. So we're always trying to figure out who those severe kids are to try to prevent problems. But about 2/3 are going to lose their symptoms. Does it mean they outgrow it? Not really, because a lot of kids will have another exacerbation in their 20s. But it's nowhere near as bad as when they're young and they have small airways. It's a chronic lifelong disease in some children, but you may have to take asthma, you may have to take medicine every day. You have to think about asthma every day to prevent problems. As I mentioned, when the symptoms go away, you can't just assume it's gone. And unfortunately, some people need to hear this. You can die from asthma. It's not something to be ignored. So that's the worst news, obviously. Oh, and I was gonna has anybody seen this? This is one of my favorite things. Can I get online and do this, you think? Can I just click on this? Oh, good, it's gonna work. This guy is so rude, but this is really funny. I hope the volume is up. Do I have to do anything here? Oh, it's working.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
Sorry, hang on. There we go.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
That's perfect. So that's why I say it's really helpful to watch and see if they're doing it right. Oh, we could watch some more House. All right. So that's it. Any questions for me before I finish? Anywhere else?
I'm sorry you guys here, but let's start with questions.
I have a couple,
Okay.
and one of the questions is, with the powder dose inhaler, is a spacer needed or not?
No, with a dry powder inhaler, no. You still need to really take a big breath, blow all your air out, put your mouth on there, take a slow, deep breath, not even that slow, but hold your breath and then let it out, but no spacer.
And what are your thoughts about when a student says the nebulizer works better than an inhaler with a spacer?
You know, it doesn't matter what research has shown. It matters what the patient wants to do and will take. So there are some children that really get a benefit from the saline at the same time they're getting the medicine. So if they really, and a lot of kids when they get really tight cannot hold their breath. So then they can use, some kids will use when they're really tight, they can use a nebulizer. And as long as they're using a mask, they're probably gonna get the drug in. It's gonna take 10 minutes and they're gonna have to clean it. But if people tell me that, I'm like, okay, that's fine. As long as you take your medicines, that's appropriate. It's hard to have a nebulizer at school. I don't think if they're sick enough, they're that tight, they need a neb, that at school, that's tough. I would say they should be using a spacer at school, and if they're that sick, they should probably have a neb at home. But either way, you can get the drug in. You just get equivalent doses, whether you use either way. And that's the most important thing. But I hear that a lot too. Anything else?
Anything else on blue jeans?
I was told most inhalers are powdered now. Is that?
No, there's more. There's going to more. There's some newer formulations coming out, and amazingly enough, people don't cough with a powder, which sounds horrible if you have asthma. But there's still a propellant. You know, the drugs that mostly get covered by insurance. First of all, it's QVAR if you're on an inhaled steroid for the most part, even though it's not the best particle size. But those drugs, QVAR and Flovent or Advair, Dulera, or Symbicort, those drugs are still, they're not powders. They're still a medication that's propelled. And some kids have trouble with the propellant, actually, because they have to be pushed out. And that's why it's important to also prime those, too, because many times if you don't prime those, and if you don't have that information about priming, if you haven't used your MDI for a couple of weeks, you have to prime that thing. Otherwise, you get propellant and you don't get drug. And then, truly, it doesn't work. But no, not yet. They're not all powders yet.
A question, and this came from other presenters as well. Why do asthma flares happen in September? What?
Probably multidimensional reasons, but number one, a lot of kids come off medications in the summer, I think, or they don't use them as often. They don't have a routine. They don't have a structured system anymore. Secondly, I think that an awful lot of children are not exposed to many viruses, and we can track viruses. We have a virus lab at the U that we track. We can just see the viruses increase in September, and most kids are triggered by viruses, so that's going on as well. And I think if they haven't had good control of their asthma, if their airways are inflamed at all, but often they could probably handle one cold, but then they get another one a week and a half later, then they get another one, and they really never really recover. In that one slide I showed you where the airways take weeks to recover sometimes, and if you get a particularly nasty one, it can take even longer. So I think that's part of the reasons why. There's other reasons, obviously, but that's some of the major reasons is the it's around. There are a lot more viruses around, and a lot of children's airways are not in good shape by the time they go to school, and they get hit with one thing after another after another. It's quick and dirty answer anyway. Anything else? Yeah.
I was really intrigued with your QI study.
Me too, it was great.
Yeah, where you were calling
Yeah.
and following up with families.
Yeah.
And I wonder, you know, a two-part question, I guess. One, how much of an impact do you think that follow-up had on the improvements that you saw? And two, well, this is more of a statement, the collaboration between a school nurse, if we could get them in schools more frequently, and the providers with that follow-up, I think would be, I would love to see outcomes of a program like that.
I would love that too. And there's a couple, I could go on and on about the other data we had about this, but first question, was it helpful 2 weeks later to call? It was when people were having trouble. It wasn't for people who didn't speak English. There needs to be, even though the phone number comes up, you know, when children's calls, the phone number comes up as children's, but still that person, and I've lived in another country for a while too, so I knew I didn't want to talk on the phone either if I didn't speak the language. It was just, it's hard to hear, and I couldn't come up with the words fast enough. So I think that's a real problem. That needs a different system. And secondly, we didn't have any home visiting. We needed that because, as you know, it all happens in the home. It doesn't happen in the clinic. So we needed to have that collaboration. We had multiple disciplines involved. We had providers and we had a dietitian if we needed it, which we didn't need very much, which was weird. We had a social worker because that's where the problems are many times, is in the home. And then we also had respiratory therapists involved with us as well. So we had multiple disciplines as well. And then we were referring kids to otolaryngology. You know, there were a lot of comorbidities involved that needed to be treated, and then their asthma got better. But we also needed, there's so many stupid rules in the way of communicating with the school nurses. But yeah, that would make a huge difference, because I think as soon as we started seeing certain symptoms, we needed to be communicating with the school nurses because, or they, actually I should say the other way around. As soon as they started seeing absences, I would love to know, because then I think we need to intervene, and that's what would make a huge difference, absolutely. Plus the home visitor. Yeah, good point. Yeah.
My name is Margaret, and I am with Molina
Okay.
as a payer. And so
Mhm.
one of the reasons why I came here is I'm hoping to get some more questions from the school nurses as to how Medicaid payers can partner with the community to reduce asthma exacerbations. And also, I just had a question. So if you have any specific questions for Molina, I would really appreciate it. And I will, my email address is available at the sign-in, because I would really like to see if there's other ways that we can be helping to manage this. And I am also involved with the asthma cohort here, which is a pilot program that we're doing at Seattle Children's, where we are doing follow-ups after ED visits, where they go and Seattle Children's makes a call, and then I make 2 calls. So we're doing follow-up over a couple of weeks, and we have seen some improvement. But my other question is about the low-cost spacers, and if that is what's the resource for that, and how can I find out more about it? And also, just as a question from the studying perspective, have you seen any increases in exacerbations since legalization of marijuana? Because I'm talking to a lot of parents who have gotten the message that you shouldn't smoke cigarettes around your children because that can trigger, but a lot of people aren't recognizing that marijuana smoke is also triggering and that it also lingers. So I'm just wanting to know if you've noticed anything in your practice.
Sorry. Oh, okay. Let me start with marijuana. You know, we're not being very good about asking, what are you doing at home? I'm asking about vaping now, and I ask about smoke exposure, but I don't differentiate what kind of smoke. So I can't tell you if I can answer that question. But what I really worry about is I have talked to some kids, teens, who think, just like alcohol, it may be legal when you're 21, but everybody does it anyway. So they're smoking, they're smoking grass too. So I know they are. So that's a problem. As far as the spacer, I put the website on there. So you can go to that website theoretically and I haven't done it myself, but my sister tells me it works. So I think that would help. And as far as your question about, I think, what was your other question about home visiting, or not home visiting, but follow-up?
Follow-up,
Yeah.
just the
as a Medicaid payer, we're looking to see other ways that we can partner with the community
Yeah.
in reducing
Right.
exacerbations.
Right.
And again, we are doing follow-up in our program, but
Yeah.
it's with a very limited, it's a pilot, so it's with a very limited number of kids. So I'm just, what the research shows is that for exacerbations, they're much more likely to be very quickly, which I think, I would really like your information on the viral study about the recovery, because I've certainly seen that this year with this virus season, which was just as big and bad as I've seen in a long time, with kids just getting multiple viruses one after the other. And so I was just curious as to see if there was anything that, just putting it out there to the community of school nurses, if there's anything that you could see that we could be doing to help prevent exacerbations as a payer.
First of all, I am so grateful for the payers that pay for the drugs now, and we can get the drugs for kids. We have less trouble with Molina than anybody else, I swear to God. We know we can get the medications. I know, thank you very much, because it's really made a huge difference in people taking the drugs if they can get them and don't have to fight for them for 2 or 3 weeks. But I think the biggest bang for your buck is home visiting, because that's where the triggers are, and that's where I think once you go there and you see triggers, you also have to then be able to have resources to ameliorate those triggers. That's the main thing too. And there's a program here, a PPIC grant here, Pediatric Partners in Care, I think it's called, where the kids are on. It's great, yeah. Some of our children have been followed them. It's very, very helpful. That's expensive, I know, but I think it's front loading. I think it really makes a difference to put the money up front and to ameliorate what you can, and then that prevents the school absence, the ER visits, the hospitalizations, and blah, 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 like that. I know, it is.
It's comprehensive and,
They're very knowledgeable.
very knowledgeable. And
Mhm.
I've been taking, but we haven't been doing home visits yet in our pilot.
Mhm.
We're working to see if there's a way we can, arrange that. And I'm just, so it's good to hear from another person.
Yeah.
I think that home visits are
Oh, it's a huge deal.
huge difference.
That's borne out in literature as well. If you can do that, if I could find money for that, we'd be doing that.
I have another question from
Yeah.
Blue Jeans.
Mhm.
Mm-hmm.
Last one, okay.
Do you have any parent-friendly brochures for educating parents?
What kind of brochures?
Friendly,
Parent-friendly. You know, where did I see these? I think, Sarah, you had them. Yep. Yep. I looked at Sarah's presentation. Yep, she's got some great ones. Mostly pictures, not a lot of words. Perfect. Yeah. So, perfect segue.
All right, thank you.
Thank you.